Very good morning, everyone. I'm Professor Iko. First of all, I'd like to thanks to Valing who has invited me to talk in this very wonderful meetings. I really apologize that I cannot attend in person because there is a clash with the university graduation of ceremony in my university in Jakarta, Indonesia. So I'd like to continue our discussion today with the topics PRP is hope or hype for rejuvenations in reproductive medicines. We know that rejuvenation is the reversal of aging, namely repair of the damage that is associated with aging or replacement of damaged tissue with new tissue. In reproductive medicines, it's very crucial issue rejuvenations for ovarian aging and also rejuvenation for endometrial regenerative in such a case like endometritis TB and also Asherman syndrome because of severe adhesion intrauterine. We know that accelerated diminishing ovarian reserve will lead to the premature ovarian aging or insufficiency, and poor oocyte quality with increasing age could result from chromosomal cohesion deterioration and misaligned chromosome, telomere shortening, DNA damage, and associated genetic mutations, increasing of reactive oxidative stress, mitochondrial dysfunction, and epigenetic alterations. If we look these figures, the dynamic of human follicular development and reserve during fetal development and in adult. We know during birth, neonatal will have approximately 1 million follicles, and then becoming 300,000 follicles whenever they get first menstruation or menarche. So that's why the optimal fertility in between 20 to 30 years old, decreasing fertility up to end of fertility around 40 years old when approximately 1,000 follicles was intra ovary when the patient's getting into menopausal age. So in the ovarian aging, later another speaker will talk about, I think not only DNA damage, but also there's a mitochondrial dysfunction and increasing reactive oxidative stress that will lead to decreasing quantity and also low quality of oocytes in the ovarian aging. So that's what, therefore, will increasing the probability of patient to have aneuploidy embryo, and of course, will decreasing the success rate of IVF and increasing the miscarriage prevalence in ovarian aging cases. This is, for example, the young ovary with a lot of primordial follicles, parental follicles, and also antral follicles. And then this is aging ovary. We only can see maybe dormant residual primordial follicles. That very important for us as a clinician, that we should make activations of the rest of residual follicles inside ovary. Many studies talk about mitochondrial transfer or mitochondrial injection together with ICSI, and then if they come from autologous germ cells, they call it augment technique, and then with this kind of injection of mitochondria into oocyte, a good quality of embryos will create it and then transfer into the uterus, and will end with the success rate of IVF for the patient getting pregnancy with the new mitochondria that come to from their self. Amides also have independently correlated with mitochondria DNA copy number in human granular cells. As we know that with increasing of age of the woman, there's decreasing at least zero point 0.4 copy of mitochondria DNA per year. So that's why very interesting if you want to see how the correlation between AMH, aging, and also DNA mitochondria. This is our study in human granular cells. There is no significantly different of mitochondrial DNA number in the group of a normal weight, obese, and also lean, in the group with LH supplementations, in the group with growth hormone supplementations. In fact, there is a negative correlations. I think this is between age and mitochondrial DNA. Whenever the age is getting older, increasing the age, lowering this level of mitochondria DNA in the cells, and also the same with between correlation between AMH and age. And then very interesting that we can see there is a positive correlation between mitochondria DNA in granular cells with serum AMH. So that's why we can use serum AMH as an indirect biomarker for quality of oocyte, since there is a positive correlation between serum AMH and DNA mitochondria. This is our study, experimental mouse models. Yeah, we use the mice struck double range, the age between 8 to 10 weeks, and then as a young rat, then we make the rat becoming poor responder by giving chemotherapeutic agent cisplatin or platinum group within 2 or 3 weeks. And then as a control, we use rat with age around 28 to 30 weeks as the old rat. Then we can see here how the growing follicles decreasing after the rat receives cisplatin 3 times. This is the growing follicles. This is atresia will increasing. So that's why this experimental rat model we use for make another interventions with PRP in the aging ovary rat. So this is the next data coming from platelet-rich plasma injection into ovary. We can see the following the follicle development in the POI experimental animal model. You can see this one, serum FSH increasing but after the rat receives platinum. Then also estradiol declining, AMH declining after the rat received the platinum, cisplatin. And then this one, how we make the rat animal models by injecting the cisplatin via intraperitoneal injection. And what happened after we inject the PRP intraperitoneal? You can see here, this is after PRP injection, the serum FSH is getting lower. This is the control, And then also estradiol, serum estradiol will increase. This is the control, this is after PRP. Serum AMH will increase also after we do injection of PRP. How was the follicular development? This is the pyramidal follicles. This is in the control. You can see the pyramidal follicle, the number of pyramidal follicle development was growth after injecting of PRP intraperitoneal. And we trying to see the mechanism why the follicular development increasing, serum AMH increasing, FSH declining, and estradiol increase after PRP injection. So we check the FOXO3 and DDX4 gene expressions. And we can see here, this is a FOXO3 after PRP injection. They will increase. This one's the dermal follicle, they're decreasing. And then this one, the DDX4 increasing after we inject the PRP into ovary. You can see also in immunohistochemical preparations. You know that PRP is now become a novel treatment in various aspects of medicine, including reproductive medicine, and more specifically focusing on infertility. Even numerous methods of preparation PRP, from whole blood collection to commercially made PRP kits, concentration and collection time still vary depending on the timing on centrifugal force. So meaning different concentration of platelet and leukocytes are obtained, which in turn impact different type of growth factors. It's very important, the growth factors. Unfortunately, nowadays the lack of standardization and preparation methods, which can potentially affect the outcomes and also reproducibility of this study. If you look these tables, we can see what is the main component of PRP. PRP consists of chemokine and cytokines, interleukin 1 beta, interleukin 8, platelet factors 4, ligand CD40, and rantes, macrophage inflammatory cytokine protein, and then also the rich of clotting factors and inhibitors, and growth factors such as TGF beta, VEGF, IGF, platelet-derived growth factors, EGF, and GCSF, adhesive protein, integral membrane protein, immune mediator. So we can imagine that a lot of things was inside PRP. So studies evaluating PRP and ovarian insufficiency, we can see here many studies, but not many well-designed studies such as prospective RCT. Many are only cohort, case series, and then non-randomized control trial. Yeah. However, we can see the restoration of menstrual cycle, pregnancy rate, and then lab post-intervention, increasing MH, decreasing of FSH. I think this is the promising data from the study about PRP. The last systematic review and meta-analysis in 2024 that randomized and non-randomized studies trying to see how the result of PRP with the self-control among women with diminished ovarian reserve. This is the graphical abstract. I think this is the diminished ovarian reserve or ovarian aging, that is PRP treatments. Most likely they did transvaginally ultrasound by ultrasound guided. And then afterward, the effect of PRP treatment towards serum AMH, FSH, and also on-top follicle count, oocyte count, embryo count was observed. Then the success rate, including biochemical pregnancy, live birth, and also spontaneous pregnancy. We can see from this forest plot the AMH level before and after treatment of PRP. So AMH level 1 month after PRP, 2 months after PRP, and 3 months after PRP. All the data show us that serum AMH is increasing much better before and after PRP injections. And then this one, the AFC level after PRP, or site count after PRP, and then also embryo count after PRP. All the parameters are much better. Then this is a biochemical pregnancies after the PRP. Most likely the study is showing the beneficial effect on increasing the biochemical pregnancy and also spontaneous pregnancy after PRP. Many studies reported that many spontaneous pregnancy after PRP. And then this is the live birth after PRP, the same thing. Half of the studies show the significantly effect increasing the live birth rate after PRP injection. The distribution of cycle outcome due to interval between commencement and PRP injection, we can see here Most likely, the clinical pregnancy will happen between 30 days until 90 days, or between 1 month to 3 months after PRP injections. I think this is correlate with preantral follicles shifting in the early antral follicle state between class 1 to 5, that is, and which is need at least 65 days for preantral follicle class 2 to become antral follicle class 5. This quite interesting that we should wait at least 1 month after PRP injection to see how the effect of our interventions to the outcome of the next intervention, IVF or spontaneous pregnancy. This is how the PRP will work after we do injection intra ovary. This is, for example, the normal ovary reserve of the follicle with high MH. Many follicles will develop, and then this is the POI, or the diminished ovarian reserve. Reserve of the follicles in low MH patient is very few. There is also general stem cells, and then by PRP, the dormant follicles mature to ovulate, I think, and then also there's a stem cell become new oocyte. Yeah, it is very interesting. There are two main mechanism how PRP can improving the condition in patient with diminished ovarian reserve, or in patient poor responder or premature ovarian insufficiency. Another interesting data also showing us that intraovarian PRP injection significantly improve blastocyst yield and quality in IVF patients. So the study trying to evaluate the effectiveness of intraovarian PRP injection for improving ovarian response embryo quality in IVF patients with poor embryo quality in previous cycles. 74 patients participated, 30 in the control group, 44 in PRP group, and then PRP was injected during the follicular phase of the PRP group. This is part of the group. I can see that the age, no significant difference. The group were comparable. And this is the result of the first control ovarian stimulations. This is the control group. Total blastocyst only around 12. Then this is the PRP group before PRP injection. You can see here the total blastocyst also 16. There is no significantly different between PRP group and control group before PRP injection. And then how was going on after PRP injection? This is compared to the control. We can see here the total blastocyst increasing, then a good quality blastocyst also increasing, and then good quality of blastocyst rate also increase. Then if we compare this one before and after PRP in the same group, this one, the good quality of blastocyst increasing, total blastocyst increasing, and also good quality of blastocyst rate increasing. Even before PRP, they don't have good quality blastocyst. After PRP injection, they have 14 to 22% of good quality of blastocyst. This 1 month after PRP injection, if they did ovarian stimulations, this is 2 months, and then this is 3 months. We can focus on the number of retrieved oocytes. 2 months, they're much better than for 1 month. Yeah, we can see the mature oocyte, total blastocyst also, good quality of blastocyst also, total blastocyst rate, yeah, good quality of blastocyst rate is much better in the 2 months. However, in the 3 months, there is no significant difference in terms of number of retrieved oocyte, and then mature oocyte. Yeah, things mature oocyte. This one before and after. Yeah, you can see here, no significantly different. So that's why maybe 2 months. Yeah, it's the better time for us for waiting before we do ovarian stimulation after PRP injection. This is the first once or second times of PRP injection, which one is better? This is before, and then this is first COH after PRP injection, second COH after PRP injection. I mean, the first stimulation, one stimulation or twice ovarian stimulation are needed after PRP injection. You can see the good quality of blastocyst, and then also good quality of blastocyst. So if we look this one, the first COH after PRP injection is much better compared to second COH after PRP injection, and then we should waiting at least 1 to 2 months. And this is the some case report from our centers. The patient, 33 years old, with history of failure of several IVF cycles because of fragmented embryos. The patient never underwent embryo transfer. This is the first ovarian stimulation, second ovarian stimulation, and then this is the third ovarian stimulation, extended long protocol, and also we do ovarian PRP. The stimulation we did 1 month after PRP injections, and we have two cleavage stage embryos, much better morphologically, and also one blastocyst embryos on day 5 that now were frozen. The second case is Mrs. 36 years old with history of failure several IVF cycles, no euploid embryos. Yeah, this is previous cycles, and then now we extended long protocols. Then also did ovarian PRP injection. 1 month after PRP injection, we do the ovarian stimulation, and we success to freeze the 2 good blastocysts, and then fortunately one of them is euploid blastocyst. So I think this is this looks how the PRP improving the quality of blastocyst and also improving the number of retrieval oocyte compared to previous IVF cycles. And this is 46 years old also. Patients failure of several of cycle IVF cycle because no good embryos or no never ET. And then we do the 1 month after PRP injection, we did ovarian stimulation. We have 2 day 3 embryos were frozen and then already were replaced with a good result at CG and the clinical pregnancy. Unfortunately, the pregnancy was ended with miscarriage because of the the non-growing of the fetus because of the maybe the embryo was unemployed. The pregnancy was ended in 8 weeks of gestational age. This is the data for the patients with intrauterine PRP with TRIF and thin endometrium in our centers. Looks that the patient's age ranging at the mean 38 years old. And then I think duration of 7 years. All the patient underwent frozen embryo transfer with HRT cycle and single blastocyst transfer. So we can see after PRP endometrium, the endometrial thickness was increasing. So the delta about 1.2 millimeters, and then after PRP around 10 millimeters of endometrial thickness, and then this one, clinical pregnancy after twice PRP is much better compared once PRP for the clinical pregnancy. And then this is all the data. Even we collected more data, PRP and non-PRP. We can see here duration of infertility, and then all the with HRT cycles, and endometrial thickness, the lining on it is 10, and then I think the pregnancy rate is about 40%, so much better compared to the non-PRP group. And then the last is about intra-ovarian PRP. This is the very few data, the pilot study from our center. This ovarian PRP, the age is 38 years old in the 24, within 27 cases. And then I think the number of transfer embryo, even no significantly difference. Biochemical pregnancy and also clinical pregnancy, it's not significantly different. all the patients are the poor responder and diminished ovarian reserve, and also some point. However, if we look to MH before and after PRP is slightly better, and also AFC before and after PRP ovary is slightly better in the case of intra ovarian PRP injections. So I'm coming to my last slide. As a take-home messages, we know that ovarian aging is intricately linked to both chronological and biological age, influencing not only the quantity but also quality of oocyte that significantly will impact toward fertility. And the study highlight the importance of granular cells DNA mitochondria. This is in our study, which is positively correlate with serum MH level and negatively correlate with age, emphasizing the role of mitochondria health in ovarian function. Intraovary autologous PRP injection in animal model has been shown to increase expression of DDX4 genes. We know this is the potentially enhancing ovarian germ cell functions, including organelle stem cells. So that's why in the case of diminished ovarian reserve or premature ovarian failure, platelet-rich plasma injection looks promising. And the last, injecting PRP direct into ovary show promising effect in enhancing ovarian response and embryo quality for patient with unsatisfactory outcome from previous IVF attempts. As we reported in this presentation, some of our patients, they have better result and improving the number and also the quality of blastocysts, and also some patient getting pregnancy with the result of euploid blastocysts. This is my presentation. Thank you so much for your kind attention. Thank you.